Hello, everyone, and welcome back to this year Asian Stigma Discrimination Forum. And I hope that you have enjoyed the previous sessions, which I found very, very rich and very glad to see all of you who are new to this forum and who have been our previous audience in the past years. So this session will be around how do people want to be communicated. We have heard from the previous session chaired by Dan Vic already about how people working in healthcare settings who are healthcare providers experience how they can address stigma by preparing a more healthy environment for people coming in to healthcare settings. We have heard a lot of good, great messages from the previous panelists. We have heard about the use of positive frame communication mentioned by APACC. We have heard about how we do not accept stigma in our healthcare setting by Iskandar, and even Iskandar mentioned that healthcare providers who cannot provide services with inclusiveness need to be removed, and I hope that that is not to be removed naturally. We must challenge the system, as also mentioned by APACC. So we really hear a lot from the previous panelists. For this panel, we will be hearing from the representative of the communities who will share with us how they would like to be communicated. And here I would like to first introduce our 4 panelists who are kind enough to be with us here this year. The first panelist is Castaneda, who is the program associate at ASEAN SOGIE Caucus in the Philippines, and this is a network of LGBTIQ human rights. The second panelist is Surang Janyam, who is the director of service workers in Group Foundation or Swing Foundation, which is an NGO aiming to protect the rights of sex workers, and also is an NGO, leading NGO in providing key population-led health services in Thailand. And our next panelist is Jemma Samitpol, who is the Thai transgender women activist with years of experience in trans advocacy. She is also the clinic supervisor for the Tangerine Clinic, which is the first trans-led integrated gender affirming and sexual health clinics in Thailand. And last panelist is Thomas Thao Sai, who is the chairman and founder of AIDS Care China, who works with the Chinese public health system to address stigma and discrimination against people affected with HIV. So without further ado, I may just would like to go straight into the discussion today for this session by using the same theme that we have been using during the last session, which is like we may want to start about what you feel as a representative from the communities are like things that we will call don'ts. Please don't do this anymore. It is so obvious. We need to be more practical. We should know already that this is the don'ts that you will need to realize, recognize, and then we may follow after that with the do's. So what you think should be done after we hear from our panelists in the past session. So by doing this, I may want to frame the first question about the don'ts in a way that I would like each of our panelists to probably mention a bit about what they feel as like the most common stigmatized or discriminating actions that the communities have been facing. And this could be like actions from actions within the healthcare settings, or actions from public communications, let's say public campaigns that target around the populations or the communities. So may I start with Jan first?
Hi, thank you so much. And I'm so glad to be here, so glad to have heard from all of you. In my own experience as a human rights advocate, uh, my background is mainly in psychological care. So we've tried to bring that into human rights advocacy. No? And when we talk about it in the context of HIV/AIDS healthcare, the very first thing that we talk about is to ensure that there is a context of safety. Because the problem, especially those facing the what we call the key populations, of which LGBTQ people are one of them, a lot of us have lived a lifetime having experienced context of a complete lack of safety, whether that's because of bullying, violence, discrimination, and so on. And those things tend to hypersensitize us to a vast array of different experiences. And in the context of healthcare, it often happens even before you step into the door. I've heard a lot of our younger human rights defenders, when we talk about HIV/AIDS healthcare, how they feel like people are looking at them funny, how they appear to have been judged even before they open their mouths, and how the space itself does not appear to be warm or welcoming. No? Because while it is fantastic that we are now working towards trying to make HIV/AIDS an issue similar to that of other chronic illnesses like diabetes, in the minds of many people, that's simply not the case. There's a lot of cultural and psychological baggage that has to be untangled there. No, and that has to be addressed in the healthcare system as early as the moment people step into the door. No, so when I think about the don'ts, I think about what exactly are those things that make people feel unsafe. What are those things that trigger certain past experiences of violence and discrimination? And one of the first things really is the way people look at them. One of the most interesting things I've heard from some of our clients is that they talk about how when they approach a person, there is a lack of smiling. And while that does seem like a very trivial thing, no? We have to again imagine where a lot of people are coming from when they say these things. What does a smile represent? Welcomeness, right? How often do LGBT people in the context of their families, in their schools, etc., how often are they responded to with a smile first and foremost? I would say, sadly, not as often as we would have liked, no. And that sort of thing sticks in one's mind, no. So really, those little things, thinking about how we can shift the way we do the littlest things, how we respond at the moment of first contact, the way we modulate our voice, the way we speak to them, the way we assume certain things about their character, and the way that we ask them questions. Often one of the things that are potentially triggering, especially to our friends who are non-binary or identify as transgender, is when during the uptake they are asked questions about their sex. Parang, are you male or female? At one point, one of our activist friends said that a healthcare worker had asked them, "Can you please make up your mind? Are you male or female?" It's that sort of thing should be unacceptable in any context, but that is the sort of thing that occurs, especially for LGBT people. So that is what I would start with, asking what exactly are the things that we do or don't do that make a person feel safe. And perhaps our other friends in the panel can share more about the experiences of the people they work with.
Mm-hmm. Thank you so much, and you brought up a very practical point. The welcoming first contact is really something which would not be too challenging, I would say. It's not like challenge the system, like as I mentioned. We need to do that as well. But this is some practical way that we can do. Smiling is something that everyone can give to other people, for sure. Thank you so much. And then can I go to Ms. Surang, please? Kathy Surang.
Thank you, Dr. Nittaya. So I'm so glad that I will be here, and thank you everyone to invite me for speak out for the sex worker committee. That's myself. I have been experienced working with sex worker for a long time. today, what I want to say, I don't want to blame the healthcare provider because we are work very close with each other. We are work like a partner. The issue what I will say today is that like okay, that is a fact, but because some of the issue that is still stigma and discrimination among the healthcare provider with sex worker. We always hear for a long time that we always hear one of the words that have been used for a very long time. And so we try to talk about this with the healthcare provider. Please don't use this word. This is not a proper term to use. This word in Thai we call แหล่งแพร่ or disease spreader in translation. This always we hear this word every 2 years. When the healthcare provider or people in the public health, they try to do the surveillance survey, and also they do a monitoring among the sex worker for they want to know the evidence among the sex worker in the community. They will use that. They will do the survey on แหล่งแพร่ That is make us very hurt because when they call แหล่งแพร่ or the disease spreader, that is make we feel like we are not a human being. They make us feel like we are the disease. We are not a human. We try to work with them, please change to use the word. Okay, if the term that they have to use that, should use the term that they do the prevalence of survey among sex workers better than they use of the word on the disease spreader. Because okay, we accept that they are call us the sex worker, but don't call us like we are the disease. Usually this term we not hear much of from the new era, because the new era, the new generation of the healthcare provider, they don't use this word, but we can hear this word from the some of the people they have been working for a long time. But we hope that sometimes we believe that sometimes they are not try to do like that, but they do that because they don't know what they do, and what they say is not a stigma and discrimination, and they do is that. And for us, that we would like to let them to think that okay, if they provide a service for sex workers, choose think that we are the human being as same as another people. When we are reach to them, we need support from them. Please ask us about what happened with us, but don't ask us what kind of job you do, or why you get infection, why you this, you that. Please focus with what problem, what we are faced. Don't focus what kind of job that we are do. Which always, that is why makes a lot of the sex workers, they don't want to go to get the service from the healthcare provider done by the government or clinic or the government hospital. That is we call a lot of stigma. For us, we already have our self stigma. We know why we come to be a sex worker. But when the healthcare provider, they ask some of the question, maybe if they not try to mean like that, but we feel that they are stigma of us, and then it make us feel very bad. What I want to say that they don't do is don't do this. We are the disease. Please look at that. We are the human being. We are the as same as another people. That's okay. My first question. Thank you.
Thank you very much,พี่สุรัง. I think this really echoed what the previous panelists already mentioned, that like we really need to think of people as a person, and talk to them, communicate to them in a way that it's people first, it's people centered. It's not just like an object carrying disease, or object performing certain jobs, sort of things like that. So that's a very important, and you have a very nice background,พี่สุรัง. I really love that. And so thank you very much. And then let's move to Jemma. Jemma, would you like to also share with us what you think is like the most common challenges faced by the communities, and maybe a little bit also about what you think like is the reason behind people doing that? that? Because I think that would be very useful for us to then talk about the do's.
Thank you, Dr. Nittaya, and hello to everyone from Bangkok. Today I'm going to share with you the 5 things that shouldn't happen anymore in the healthcare setting when it comes to serve or work with the trans people. Very nice and clear. The first thing is, do not prioritize prevention and treatment over gender-affirming hormone treatment and surgery for trans people. Because lots of people still see gender-affirming hormone treatment or surgery as a cosmetic surgery or cosmetic purpose for trans people. So there's so many times that doctors sort of prioritize treatment and prevention over these. And I have heard a lot from the community members that, especially those who just found out to be HIV positive, that the doctor said, please take off your hormone, stop taking hormone, do not take any hormone. And it feels very, very negative, and it feels so bad, and it's not acceptable at all for the trans people. And what I'm trying to say here is that it might be because of the safety issues or whatever that you have. But then again, gender-affirming hormone treatment, surgeries, they are very, very important to most of the trans people. They mean a lot to our health, our mind, our body, and our well-being. So they have to be together, they have to go along together. And what I like to say is that maybe if the healthcare provider or the doctors can take their time, explain, and give a little bit of a reassurance to the trans person, that would be very, very good. The second thing is, do not tie us with beauty. And do not overcompliment. Because what we hear, what we heard, and I face it myself, and it's still happening almost all the time when I go to the hospital. I have the, doctors or nurses or the healthcare providers keep saying that, like, they keep showering me with the compliments, like, wow, you look like a woman. You look so nice, you look so beautiful. I wouldn't be able to tell, oh, look at you, And when you say this, almost all the time, you kind of check my body. You look at my chest, you look at my bottom half, and you see what kind of surgery that I've done, that I've been through. And I would say that it feels very uncomfortable. And most of the trans people do not actually feel like that's the right thing to do. But I know that this might be the way that you want to show that you are nice, you are being friendly, you want to break the ice, you want to be like, getting the conversation going on and getting to know the person. But then again, there's other way that you can make a conversation by avoiding making all these comments. Because, you wouldn't say all these things like to non-trans people, like, oh, you look so beautiful, you look so like a woman. I wouldn't be able to tell you, wouldn't say that to other people. Why would you say that to trans people, right? The third thing is that do not pathologize us. I mean, this is the first year that the WHO has implemented the ICD-11, and it has been removed, being trans has been removed from the section of the mental health disorder. So I don't know if is it hard for some people to actually give up the idea that we are sick, we have a disease, or you being ignorant, or even if you don't actually have the updated information about this, but we are not sick. So when we go to see doctors, when we go to healthcare setting, try not to, if you got this idea in your mind that we are sick, we have the disease, and you feel like you feel sympathy for us, this is not what we want. We want empathy. We don't want people to feel sorry for us being trans person. We might want some kind of, medical support, but not because we having a disease. Not because of us. And the fourth thing is that there are lots of stereotypes about trans people. You have seen it a lot, on the television, on the media campaign. You might have heard about it, in your society or the people that maybe it's like trans people are so obsessed with sex, or we are very good at dancing, singing, or performing art, stuff like that. We are very good at being makeup artists. And, all these stereotypes, you might not even realize that you have it, but then definitely affects, your conversation, definitely affect the way that you speak to us, and definitely affect to how you expect us to respond to your conversation, right? So it is very hard, but then again, what I'm trying to say here is that trans people are like other people. We have like, all the diversity. We are different in individuals. So do not stereotype us and treat us like other people. The last thing is that I'm not sure if this would apply to other countries, but in countries like Thailand, which we don't have gender recognition law yet, which means that on our ID, we cannot change the gender marker. We cannot change the gender title. So if you work in a healthcare setting, try not to use all the details you see on the ID, because there's a case that you might be misgendering people. So what you can do is that you just have to simply ask the person on what would be their chosen name, or what would be the pronouns that they would love to, or how they would like to be addressed. So these are the 5 things that I think it shouldn't be happening anymore in this year 2020. And this is for me right now. Thank you.
Thanks very much, Jemma. I think what the 5 points that you raised actually can be applied to other populations as well. This is also, I feel it's true not only for healthcare settings, but also true for those of you who may be planning like public campaigns towards key populations. So don't prioritize HIV over gender information. Don't over compliment. I think this is very, very common for trans people. And then don't pathologize, don't stereotype, and don't misgender. And I would say that like for many languages in our region, we have a gender neutral language terminology, and we don't need to like go with like the he, him, his, her thing. We have so many other pronouns that we can use in our language. Thank you very much. So let me go to Thomas, please, for our first question about what do you think are the don'ts that you would like to highlight? Thomas, I don't think I can hear you well.
Oh, actually, I was
okay.
muted.
Yes.
I was muted.
Thank you.
Hi, thank you, Dr. Nittaya. I'm the last one, and actually, a lot of content Jen and Surang and Jemma has mentioned. So I think only a few points I could raise is, I think a lot of people feeling of the stigma is like, I think is for the language, one is a lot of doctors, when they're working in the HIV department, especially the public health sectors, I mean the government hospitals, and the attitude is impatient. The thing is like when they talk, and because HIV, I mean in China, the doctors, they don't get much benefit from the free treatment program, and then sometimes they are kind of like they're not really love their job, and when they talk to the patient, they're impatient, and the people living with HIV, they're super sensitive about this when they're interacting with the others. So when you become impatient, and that makes the people feel very bad, and sometimes I met a few cases, the people say, I don't want to go to see a doctor anymore because I feel very uncomfortable to seeing the doctor. And then the second thing is about, besides of the oral language and questioning, and there's a body language as well. Like some of the doctor, nurse, medical staff, they try to keeping the distance from the client, and compared to the other hospital, other medical services, they try to keeping a distance. And also in some of the cases, normally protection is not required. They put on extra protections. So I think, for example, people holding the medical record, and then anything hand over to the client, and they will wearing a glove to holding it, which in the other cases is not necessary. And also, even in some of the places I ever seen that is they don't receive the paper hand over by the patient. They will use a clip to take it. And so all this make the people feel very uncomfortable. And also the other thing is like asking the sensitive question about how you get HIV. So and especially in the medical setting, when you're asking, the people are difficult to answer and feel nervous and uncomfortable. And in some of the program for the HIV prevention, they even telling the doctor, so by the end of the treatment, and we'll tell the people, say, oh, be careful, don't transmit it to the others. So I think these messages, yes, they don't actually not cooking the language before they deliver to the client and make the people feel very depressed after seeing the doctor. So I think these are a few points I can feel, but this is very linked to the section 1, the quality, the training of the staff, and the compliance. Actually, many people, they know, even many doctors, they know you equal to you, and but the problem is from the knowledge to practices, still a big gap. I think more efforts needs to be put on addressing such challenge. Thank you.
Thank you very much, Thomas. I think you brought up very important points, and although it's very obvious, but we still see these practices nowadays. And as Jemma already mentioned, it should not be in this era of after 40 years of we knowing HIV, right? And you know, like comparing this to COVID-19, you may still see like many healthcare providers who wear full PPE gown just to give vaccination to people, and it's like repeated the history again and again. If you start dealing with some epidemic with fear and not evidence-based ways of dealing with the epidemic or pandemic. So here we also hear a lot of similar suggestions that Jan already brought up earlier about the language, and it's not only oral language, speaking language, but it's also body language, in which I again would like to say that it could be like some practical points that we can do right away. I mean, we know that we need like more education to public, education to medical students, education to healthcare professional students, but we will then need to wait a decade or longer before those people can become the main practitioners in our healthcare systems. But what we can do right away is probably to point to some practical actions that should not be done anymore. So then I may now want to like come to the second question, here I would like to ask you to like maybe point to some reasons that you think has been like the main reason behind the discriminating actions or stigmatizing action that you have seen towards your communities, and then to propose with that reason and what we can do to like address them, and that should be considered like the do's thing here. So may I start with Jan again?
Yes, thank you. You know, I would like to start with some points raised by Thomas and Jemma. Thank you so much. And while it's pretty obvious to everyone here by now that discrimination is a problem, that's probably one of the barriers, no? And that sort of thing starts from quite literally from the moment you're born. up until you decide to take your first HIV test, which hopefully is not too old. I for one believe that people as young as possible should be able to access this kind of treatment. They should be able to access this kind of education, etc. So I'm hoping that unlike myself, who was exposed to HIV/AIDS treatment and advocacy very, very late in life, I hope more people are exposed to it much earlier on. But really, besides the discrimination, it's really the response to discrimination that is now posing a barrier. Jemma put it this way, the way that some doctors, some nurses, healthcare workers, they try to overcomplement, to try to overcompensate, trying to be friendly because, it does come from a place of nervousness. They don't want to do anything wrong, and they end up doing something, honestly, a little bit idiotic. You don't expect that kind of behavior with other patients, right? So why should trans people be any different? But it is what we call a bid for connection, and those bid for connections do tend to, dip one end or the other. And what Thomas said earlier about how knowledge-wise we understand that U equals U, but doctors and speaking from the perspective of some colleagues with whom we work with, a lot of them are still quite uncomfortable with trying to communicate U equals to U, not because they don't think it's true. Like, they've seen the data, they know how the numbers work. But it's about what they feel like the consequences might be about that kind of messaging. And again, that comes from a place of prejudice and misunderstanding. They're concerned that if we start to talk about U equals U, then there will be less condom use, for example, or less PrEP intake. And well, I mean, as medical professionals go, I do feel like that is a legitimate concern for them. But you do see the disconnect between what the evidence ought to suggest us to do and what, in practice, given our context, our culture, and our background, what we actually do. So how exactly do we get through that? Well, the first thing that I would personally like to recommend to everyone is to try as much as possible to get out of our own ways. What do I mean by that? It's about recognizing that we do have prejudices, right? And recognizing that there is value in establishing a context of safety. We do not assume safety. And I don't mean safety as in safety from bodily harm, safety from violence, although of course that is important. But really the emotional and psychological safety, ensuring that people are working on the same page. So for example, something as simple as, I can't remember who mentioned this, but is simply asking, is it all right to ask you what pronouns you prefer? Is it all right to ask you what names you would like us to use? Because at the end of the day, everyone knows that in the personal information sheet, you're going to have to write your legal name, at least in the Philippines, right? But we're not basing all our interactions on the personal information sheet, right? We're basing these interactions outside of that. So sure, that's fine. Put your legal name there. But during your interactions with the doctor, with the medical technologist, what would you like us to call you? What is the name you prefer? What do you prefer to be called? He, she, or they? These are the kinds of bids for connection that actually help the relationship flourish. No? And this might sound a little bit counterintuitive to a lot of people because we want the general expectation of our doctors and medical professions that they ought to know everything. They ought to know how to take care of us 100%. But we're human beings. We can be stupid from time to time. And that should be part of our process, really. I think also this is what Thomas alluded to, like during the interactions, right? It's okay for the doctor and the professional to say, I hope it's fine that we ask these questions. These questions are about your health, and we want to ask these in order to make sure that we're getting everything right. Is that okay? Yada, yada, yada. That kind of line of questioning establishes that relationship, because on the one hand, you can go straight in and be aggressive about it. It's like, where did you have sex? Or how did you get it? Although to be honest, the question of how did you get it might not even be appropriate in most circumstances. I don't think we really ask people how they got diabetes, right? I mean, we normally ask questions about diet and lifestyle, but we don't really ask them, how did you get diabetes? And in the same way that we were probably asked about sexually transmitted diseases, right? Like, is it okay if we ask you what was the context? Is there something you're curious about? Did something happen? Really establishing that sense of safety and really that sense of camaraderie. And as Tomas mentioned, again, be patient because we're not dealing with the flu. We're not dealing with something you just give over-the-counter meds for. We are dealing with a condition that unfortunately has a lot of cultural and emotional baggage, and we ought to treat it that way. So just to summarize, just be patient. Don't assume safety. Establish it in the way you speak. The simplest bids for connections, asking questions like, is it okay if I ask you this, or what pronouns would you prefer? Is it okay if we call you this way, etc., etc. And really just showing them that you're human too, right? And this is a working relationship you have with your client. And yeah, that for me is the place to start. And then from there, you can work on the unique circumstances of each individual as they present themselves in the clinic or in the doctor's room.
Wonderful, Jan. I think that's very applicable to especially the medical system, healthcare system in our region, which is very paternalized. In a way that like you see doctors as someone who knows everything, and like for those who are healthcare workers among the audience, I would say that we should not be afraid to ask. We should not be afraid to lose face. We don't know everything. We are human beings. We can ask, and people appreciate that we ask them directly instead of we assume that they would like us to treat this way or that way. So that's a very important point, Jan. And then can I have Surang next to share with us about what you think should be the do's?
Okay, thank you, Dr. Nittaya. What we should do for the do. The first the first issue I still use on the term of they should use is I think this right now is good. The term what they use to call they call the key population. Not use the high risk population. I think this is good. That is they can reduce the stigma among our target. And also another thing that is they have to do, because we know that the healthcare provider, they cannot do anything by themselves because they don't know everything, and then they don't have to do it if they don't professional in that part. Was able to say that they should accept the service is run by the community people. That is mean can help them. They don't have to have a lot of the workload. And then if they are accept the service is run by the community people, that is mean we can helping them to fill the gap that they cannot provide the service for the key population, because we know how to deal with our friend, we know how to deal with our sister and brother, and then we know what kind of the language, which word that is we not make stigma for our brother and sister, and we know the lifestyle of our brother and sister. They don't have to try to do, and then it's not fit what we want, and let's we provide the service. And also they should accept our service equal like the service what they do, and also we have to work like a partner. They have to forget that we are not trying to be the competition, but we try to support the sum of the work that they cannot do very well. And also what we want to see that, okay, when they are accept the services done by the key population, and then they should accept that, okay, the key population less health service should be on belong of the national health care system. And then also they should support us, as same as we are like the government setting. And then the lucky us, I would like to tell you last week the NSSO they announced that they are accept the services run by the NGO. That they accept that is also on the system of the NHSO that okay we can provide the HIV service and then they can refund the money directly to the NGO. This is we want the healthcare provider they accept like this, and so we want the government they continue to express the idea like this. Better than they have to do anything, but they cannot do so the good quality, but let us to work with them and do with them, and then we can work together, and then for make sure that is we can reduce the stigma and discrimination among our brother and sister. Yes.
Oh, thank you very much, Mr. Surang, for sharing that recent success in Thailand of the Ministry of Public Health and the government payment system. Demonstrated that they have trust in health services provided by members of the communities, which is certainly one of the challenging the system thing that we can practically address stigma and discrimination by establishing a parallel healthcare systems run by the populations themselves. Thank you very much, Kapi Surang. And now to Jemma, please.
Thank you, Dr. Nittaya. I think we have heard a lot of the dons from Jan, from Khun Surang, and from Thomas. I would say that as a health service provider, we can be prepared. We can do things to prevent this to happen. It is quite boring maybe, but and again, we have to do some training. It can be like a comprehensive training. It can be like a sensitizing training, gender sensitization training, and all the stuff that if we can collect all the dons, all the things that we can hear from the community, from the clients, and what kind of things that they don't want to be treated, what kind of things that are still like a wrong kind of action, wrong kind of questions and things. We can put them together and put it on a training. And of course, we can make a mistake and we can always apologize sincerely. And, end of the day, even if whatever you say or the action come out wrong, but it's sincerity that we can feel. And that's for me. Thank you.
Oh, thank you, Jemma. That's a very good, another good point for this paternalistic healthcare system that healthcare providers should know that they can also apologize when they do mistake. That's not equals losing face, so please do that. And then the training part is also very important, so thank you for emphasizing that again. And now let's move to Thomas, please. Thomas, I think you are still on mute.
Sorry about that. Stigma and discrimination, as we mentioned this for 20 years or more, right, since the beginning of HIV/AIDS. And we are having I think we're making a lot of progressions on the medical treatment side, but we don't see much progression on the stigma and discrimination. So when people doing some evaluation about stigma and discrimination in the society, in the community, there was not much change. And I think that we did make a lot of efforts, but I think one thing is missing is in this in the HIV service facility, we are missing one important part, is the psychology gist. And I think behavior change, communication, we're always talking about that, but we don't really have a good methodology, no continued follow-up. We only by PPT, that doesn't change the people. And I think interperson communication is very important. Like community participation, peer influence, peer counseling, that works very good, but we're still not getting professional psychologists to getting involved using professional techniques and knowledges to making the support system there. So, and consistently, like we spend a lot of money on the research, on the medical care, and then we make a lot of progression. But now I think it's the time we need to think about mental health care. It's not just about the HIV community. It's also the service provider side. And I think this is like creating a harmonious environment, and then the people's thinking will change. I don't believe any medicine can simply treating these units, but methodology, technique is needed. That's my comment. Thank you.
Mm-hmm. Thank you so much, Thomas. I think you have pointed to the aspect of HIV and sexual health care that has been missing for too long. The mental health, the psychology, the seriousness of communications within this HIV and HIV and sexual health care. So that's very important. And we will have time for all four of you to join us in the next session to discuss with the other four panelists together with Danvik as well. But before I end this session, I would like to thank all the four panelists so much. I have learned a lot, and I think the audience here also have learned a lot directly from you. And these are all practical points that we should be able to adapt to quite easily. For me, I myself agreed with all those points that you have raised in a way that we may need to address this in a very systematic way. But at the same time, when we talk about training, I think we should realize that it's not as simple as any training when you discuss stigma and discrimination. It's just not that you can remember what to do and what not to do, because it could be new situations that you will make mistake again if you don't really understand stigma and discrimination, and if you don't apply stigma and discrimination to many other aspects of life. It's not only stigma and discrimination about HIV, it's beyond HIV. And only with you have stigma and discrimination integrated into your life, into any actions that you are taking, then you will not be able to address stigma and discrimination among HIV affected populations. And even if you can do that, then you will face another burden of stigma discrimination towards substance use, towards LGBT, never ending. So I just would like to end that it's such a cross-cutting issue. So now I would like to thank all the panelists again, and then we'll invite everyone to join us in the next session. Thank you very much.